Hello, everyone. Welcome to this free webinar presented by WePast. I'm your moderator, Christina Ruiz. During this webinar, feel free to use the chat to ask your questions and discuss the topic. We will take time after the presentation during the Q&A to answer these. Throughout the webinar, we will stop the presentation to review. Look for the multiple choice review questions, which you will be able to answer in the polls section. Please go ahead and respond to these questions as they come up. You will have less than a minute to answer each one. This and other recorded webinars are available to WePast subscribers 24 hours a day, 7 days a week. Be sure to register through wepast.com to become a subscriber. Today's topic is titled Strategies for Effective Physics Plan and Chart Review in Radiation Therapy, Report of AAPM Task Group 275, presented by Dr. Anne Greener, Chief Therapeutic Medical Physicist in Radiation Oncology at the East Orange Veterans Hospital in New Jersey. Thank you for joining us, Dr. Greener.
Thank you. Well, welcome. I hope to summarize TG275 in 1 hour, even though it took us a few years to actually compile the data. As we go through the talk, you'll see pretty much how much data we did have to accumulate. And the document was just published, which was very nice for the team. The objectives for today's seminar are to compare and contrast prescriptive and risk-based QA. I'll be introducing the FMEA method, which is the failure modes and effects analysis, and illustrate results for the weekly physics chart check. The TG275 team was originally formed from members of the Working Group for Prevention of Errors, which I'm currently still a member of. It was primarily radiation oncology medical physicists that represented the academic community and government facilities throughout the United States. We did add a member of medical dosimetry, since medical dosimetrists in many facilities do have the responsibility of doing weekly chart checks. Here's a list of the members, and you can see that they do span all over the United States and even Canada. We have one member from Toronto. Okay, TG275. The charges of our group were fourfold. We wanted to review the existing data and recommendations for physics plan and chart reviews, provide survey information of the current practices, and then to provide risk-based recommendations for these reviews. This is something different than many other task groups. And lastly, of course, all task groups provide recommendations, but we specifically wanted to report recommendations not only to the physicists, but also to software vendors. We did a literature review, just like all the other task groups, and the best way to start a task group. We looked at many practice standards, particularly TG40 and TG100. TG40, and then followed up with TG142, were the two task groups that presented information and made recommendations specifically about quality assurance in radiation therapy. And TG100 addressed that problem for how to then recommend guidelines, or how to recommend analyzing QA in radiation therapy using a whole different method than was used in the past. In 2016, we released our current practice survey. Over 1,300 people actually, medical physicists self-reported as working in a clinic, either in the United States or Canada. So those were the responses that we included in the analysis of our survey. We decided not to include any other non-US or Canada medical physicists because they're not necessarily following the same guidelines and regulations that we have in the United States. So I'll discuss some of these results later on, but definitely look for the publication later on this year because it is pending publication. So the most focused that we were in this particular task group was we needed to tackle the risk-based recommendations as opposed to what is currently in practice and what the panel of experts feels we need to recommend. So what is the difference between prescriptive and risk-based TG reports or recommendations for QA? Here's some examples, and just by giving you examples, you might have a good idea. TG40 and TG142 were prescriptive task groups. They formed a panel of experts. They reviewed the literature. The panel of experts either did a survey or understood what the current practices should be and therefore recommended them. TG40 was released in 1994. A lot of the QA reports a lot of the recommendations in TG40 evolved or didn't evolve because the equipment and the technologies evolved. Then versus the two reports that I have here, TG182 and TG275, these followed a risk-based approach to recommendations. So as I said, prescriptive approaches usually will have a panel of experts. They'll review the literature. Primarily, their results are based on functional behaviors. Their recommendations are based on functional behaviors, failures of equipment or software. There's some consensus of opinion within the task group. And then guidelines are created that specifically give the tests, the frequency of tests, and action levels that are necessary or recommended. On the other hand, here's an example, but here's an example from TG142. You see that there's a test, the frequency of the test daily, and the type of test it is, whether it's a functional test or whether it's looking for a specific application for the tolerance, and it gives the tolerance. You won't find these tests in these types of tables in TG275 or in any risk-based application. So risk-based recommendations are based on, again, a panel of experts gets together, literature review is done, but it's based on clinical processes, not just failures of equipment and software, but also failures in personnel and organizations. It takes more of a prospective approach to QA, and it uses some sort of structured methodology. But just like prescriptive, we do create some kind of guidelines, but not as specific as the prescriptive. Here's an example that you might see in TG 275. Looks very different than the ones that you see in either TG40 or TG 142. Here's your first review question. Only risk-based approaches to QA recommendations include panel of experts, literature review, failures of personnel and organizations, guidelines.
All right, great. This question is up in our polls section. You can go ahead and respond now in real time. I want to make sure to give everyone a chance to answer this. You won't have much time to answer, so please be sure to answer it in the polls before we move on to the next section. And if you have any questions for Dr. Greener during the webinar, please be sure to ask those in the chat window, and we'll be going over those questions at the end of the presentation here. So any questions that you have for her at any point, just go ahead and drop those in the chat for us. All right, it looks like folks are weighing in, and a lot of people seem to be getting the correct answer here. We can go ahead.
That's good.
Go over it.
Okay. I'm going to, Christina, will you end the poll? Okay. Yes, the correct answer is number 3, failures of personnel and organizations. Okay, I would be definitely remiss if I didn't review failure modes and effects analysis at this point. So here's the Cliff Notes version. All right, it's a tool developed to identify malfunctions in a process. It's typically used in manufacturing, but was adopted by TG 100. The FMEA identifies high-risk activities that result in a balance of safety and quality versus resources that are available: equipment, software, personnel, and organizations. Finally, these high-risk activities are used to develop some sort of guidelines or framework for a QA program. FMEA should be an ongoing process where the organization or the team that's doing an FMEA will evaluate how severe the failure will be if it goes undetected, how often the failure occurs, how difficult it is to detect the failure at given points in the process, and then the product of these three terms result in a risk priority number, or RPN. So as you go around the circle, you obtain these RPN numbers, and then you decide which are the high risk values versus the low risk failure modes, and you can take actions. Then later on, further down, maybe 6 months or a year later, you do the same thing over again, and you can check how well you've been doing. So how to implement the FME process, and how did we implement it in TG 275? Well, first we had to choose a process, and we chose the physics plan and chart review. I have to stop here for 1 minute because we had so many subgroups within that. So the subgroups that we formed were the initial plan and chart check, which is the time that the physicist will check the plan and the chart prior to or soon before or soon into the treatment. Then we had a weekly chart check subgroup, which looked at everything, all the checks subsequent to the weekly chart check, to the initial plan and chart check review, which included weeklies as well as an end of treatment. And then we had two other subgroups, one to specifically address protons and one to specifically address HDR. So hopefully, time is right, we'll get through all of it. After we chose that process, we worked together, the team worked together to try to map out the process. And then we created a process tree, which I'll show you. And a process tree is basically what comes first, what comes second, what comes third, what are the individual sub-processes within those general categories, and how are they all interrelated. And then lastly, we evaluated each step and asked a whole lot of questions to begin to prioritize these failures. And these are the questions that we asked. Ultimately, we assigned a numerical value for each failure to help prioritize the risk. So we start with the process, and we discover that there are so many steps in the process of checking a plan and a chart. They could be as simple as MU. Is the MU in the plan equal to the MU in the chart? Or it can be as complex to see about tumor coverage or DVHs. When you begin to map out a process, it can start manually. And this is just, a funny slide that actually I used at one point to do an FMEA. But this is not mine, but I used sticky notes on a wall at one point. You can also use a homegrown PowerPoint. You can create your own process tree and mapping out the process. You can use software that gives you a little bit more details and more complex. This is the example that's in TG 100 for the process of planning and delivering IMRT. It's meant for you not to see. You can look it up in TG 100. In TG 275, we decided to adopt a process tree that was recommended. It was actually presented in a consensus document, which is the recommendations for incident learning database structures in radiation oncology. And it is now very, very widely used. It's a high-level process tree, but as you can see, we have the first 4 steps are involved in the initial plan and chart review, the next 2 in the weekly chart reviews, and the final one in the end of treatment chart review. Next, we need to identify all the potential failures by their failure modes and causes. So what could go wrong is the potential failure. How could that happen is the failure mode, but why did it happen is the cause. And we assigned 3 different values, 1 for occurrence, 1 for detectability, 1 for severity. And by multiplying these numbers out, the product is called the RPN number, or the risk priority number. Review question number 2. To rank the risk of all failures, one must determine the following: how likely the failure mode is to occur, how difficult the failure mode is to detect, how severe the effect of the failure mode is if it goes undetected. All of the above.
All right, great. Looks like some folks are already weighing in on this poll question, getting the hang of it. So we have a lot of people in the room today, so we're going to make sure everyone gets a chance to answer this question before we move on to the correct answer. And likewise, some folks have already started to drop their questions in the chat for the Q&A, and I encourage you all to do that at any point during the webinar before we reach the Q&A portion at the end. We'll be going over those questions, so stick around for that at the very end here. All right, looks like we've got some consensus here on this answer.
Absolutely.
We can go ahead and I'll end the poll now.
Okay. And the answer is all of the above. Great. I guess everybody knows what an FMEA is. This is terrific. We'll just go on. So I'm actually, can I just go back 1 minute? Yeah, okay. I'm actually part of the weekly chart check subgroup. And in the weekly chart check subgroup, one of the potential failures would be that the patient did not receive the correct treatment. And then the failure mode, I've listed 2 failure modes here: incorrect dose administered, or the fraction not delivered as intended. The causes can be multiple. For the first failure mode, we identified patient was unable to physically maintain the position for the treatment, or patient not properly identified and treated with another patient's fields. For the second failure mode, fraction not delivered as intended, there was 2 causes identified: inattention by treatment therapist during pre-treatment imaging, or inattention by physician during image review. If anyone's ever attended any risk-based, any risk-related seminar or slideshow, you recognize this slide. So what does Swiss cheese have in common with FMEA? Well, imagine each hole represents a failure. Large holes represent a high probability of the failure not being detected at this process step or slice of Swiss cheese. The smaller ones represent a lower probability of the failure not being detected and then thus possibly stopped at the process step. If all the holes in each slice line up, the failure mode makes it through the patient, and you end up having an accident. So here's an example with chart checking. Once the CT data set is exported from the planning system into the delivery system, there's a possibility that maybe the incorrect CT data set would be exported. Importing the incorrect CT data set could also be a failure mode and cause at that particular slice of Swiss cheese. Then we can have an incorrect fusion at the treatment console by the therapist, or an inattention to the MD during image review. Now, let's look at how we determine the risk priority factor. This is just a review for you. The occurrence is how likely the failure mode is to occur. Severity, how severe are the effects if the failure mode goes undetected. And detectability is how difficult the failure mode is to detect before the patient is affected. We decided to use, well, this is the table that came from TG100. So we used this table. Their relative values going from 1 to 10 for each of the three categories, each of the three values, the occurrence, the severity, and the detectability. They're relative to one another, but technically they go from a value of 1, which is very unlikely or no effect, or can easily be detected, all the way up to 10, where the failures are inevitable. They're always going to happen. It's going to be a catastrophic event, and there's no way we can detect it. High risk is defined as high severity and or high RPM. Using these relative values, a high risk failure mode requires intervention or results in death. So while the occurrence and the detectability play in with the RPM, we also look at severity very strongly, because if the severity is catastrophic and occurrence and detectability are very low on the scale, we need to pull that one out and call it a high risk failure mode. The accident that brought focus on safety in radiation therapy is this one. In 2010, there were 3 articles, and it really came to light when this particular patient, who wants to be able to tell his story even after he died. So it's where there was a very high complex treatment that resulted in a very serious complication, meaning death. All of the holes in the Swiss cheese lined up. And when we went back to, people went back to analyze it, they realized that there could have been many steps that could have detected this problem, and the result would have been less severe. Review question number 3. What 2 factors determine high-risk failure modes? High occurrence and or high RPM, high severity and or high RPM, low detectability and or high occurrence, high severity and or low detectability.
Okay, great. This question is up, and I see a lot of folks are already weighing in. Looks like this one was a little trickier than the last 2. So we'll just give everyone a moment to put their answers in before we end the poll here. And I'm so glad that so many people have asked some questions in the chat, which is great. It looks like we're going to have a good Q&A after the presentation. So be sure to stick around for that. And if you have any other questions for Dr. Greener, make sure you ask them there so that we can make sure we get to them at the end of the presentation. All right. Wow. Looks like there's a big split here.
There is a big split.
I'll go ahead and end the poll.
Okay. By pure definition, it's high severity and or high RPM. And I see that there are a few people that disagree here, so maybe we can have some discussion later on.
Yeah.
Okay. So as I told you, since I was a member of the weekly chart check subgroup, I will present the results of TG275 with regard to something a physicist does more than any other task, and it's billable. So what do you check on a weekly physics chart check? Here's just a partial list of the items that our subgroup identified. I'm sure that at least some of them look familiar to you. And some might not even be able to be detected on a physics chart check. For example, accurate setup. How do you know on a physics chart check that the patient was set up properly when you're reviewing a chart? But what did we find using FMEA when we were looking for these high-risk failure modes? These were some of the failure modes that we actually found. The fraction not delivered as intended. Take a look at the rest of the list and see how many on this list you would easily catch on a physics chart check and which may be difficult. Which are more likely to occur in your clinic? Which would lead to a severe effect if never detected? Basically, there's no real correct answers here. It's based on your process in your individual clinic. And it's based on this graduated scale from 1 to 10 for each one of these three factors, O, S, and D. And when you have a group together, each member of the group would score the FMEA cause combinations, average them, and calculate the RPM number. Here are our results for the weekly chart review. In TG275, we originally identified 138 failure mode causes combinations. So for some failure modes, you'll have multiple causes. 30 of them, or 22% of them, had high severity scores. And we decided as a group to choose 4 as our cutoff point. 37, or 27%, had high RPM numbers, and we used an RPM number of greater than 100 to decide whether it was a high failure mode. 55 failure modes had either a high severity or a high RPM number. But what was very interesting about this was only 20 of them, or 36%, about a third, were detectable by a physics chart review. And 31, or over half of them, would not have been detectable by a physics chart review, but maybe by another individual, namely an MD or an RTT. Okay, before we go through some examples, here's the scale again. So we can look at, just keep these in mind, values from 1 to 10, and what they each mean for occurrence, severity, and detectability. Okay, here's example number 1. These are true examples right out of TG275. The failure mode we identified was the patient missed treatment. The causes, we defined 4 causes. Patient did not show for treatment, patient too ill, no transportation, patient not informed of the schedule. Now you can see what we scored, our average. These are average numbers for our subgroup for the occurrence, severity, and detectability. And then we multiplied those values to get the RPM. These were basically all low risk combination failure mode causes. So they ended up lower on our list. The next group represent medium risk, alternating fields not delivered as intended. You see a little bit more of a variety now in the RPM numbers. Scheduled incorrectly, therapist inattention, inadequate RTT check, and prescription inaccurate or incomplete. The RPM number for a prescription inaccurate or incomplete was higher, and the inadequate RTT check was much lower. You can see severity kind of stayed all about the same. Here's a combination of some low and medium risk. SSD check not performed as per policy. SSD not readable. Therapist inattention, and therapist not aware of the policy. It's a combination of low and medium. The RPM number, especially for the therapist inattention, is a little bit higher, and we have 2 out of 3 of those severity numbers that are getting a bit higher. Example number 4. Pacemaker not monitored according to policy. Causes, no instructions in chart, therapist inattention, and telemetry not scheduled. Now we're getting into that high risk category. We're getting RPM numbers, 2 of them are over 100. And the severity, remember we chose 4, so all those severity numbers are much higher than 4. So they're all considered high risk. Review question number 4. Choose the failure mode cause combination, which would be considered a high risk fraction not delivered as intended / incorrect field name. So that's a failure mode and a cause. Fraction not delivered as intended or because of incorrect plan loaded after replan. Fraction not delivered as intended because it was they were unable to treat due to potential collision. Fraction not delivered as intended because the treatment schedule was scheduled but not delivered.
All right, great. This poll is up and available for anyone who would like to weigh in. We'll just give everyone a moment to answer. I don't want to take too long, and it's great that we have some questions being asked in the chat for our Q&A. So we have just another maybe 20 minutes here before we wrap up the presentation, and then we'll get to the Q&A portion. So I want to make sure that everyone goes ahead and asks their questions for Dr. Greener. All right, looks like a lot of folks here. We have some consensus, and I think they're getting the correct answer. I'll go ahead and end the poll now.
Okay, next time I'm going to make my questions a little harder. Yes, the correct answer is number 2, fraction not delivered as intended is an incorrect plan loaded after replan. You'll see that the RPM number is at least 100. It's 100. Remember we said greater than 100, but it's 100. And the S is also 5, which we chose 4 to be. So it's both. It meets both the high severity and high RPM number. Now let me give you a glimpse into results in the other categories, starting with the initial plan and chart review. Now with the initial plan and chart review, we're looking at the first 4 steps in this process tree, from patient assessment down to pre-treatment review and verification. The initial plan check review was the lengthiest and most intensive because, quite frankly, there were so many items to check. There were a total of 594 failure mode cause combinations. And here's a subset of the failure modes with RPM numbers greater than 100. See if you recognize any of them. Have you found them? Will you add them to your list? Here's some more. Some, as we said, with the high-risk failure modes, may not be able to be detected by a physicist at the time of chart check. Here are 4 examples of failure mode cause combinations for each of the 4 process steps that pertain to initial plan and chart review. All had an RPM number greater than 100 and were considered high risk and had high S's, high severity. The first one in the list was the highest ranked failure mode of all. So in the patient assessment process step, there must have been, well, the failure mode that we identified was miscommunication about prior dose, with its cause being information not communicated or available information was incorrect. So that was the highest one of all the failure modes that we found, not just in that process step, but all of them together. Imaging for RT planning, it represented the simulation step. Inappropriate abdominal compression used because of too little compression and does not limit motion enough. In the treatment planning process step, here's an example. Dose in the plan does not match intended dose because the wrong prescription provided to the planner, either by verbal, email, or the prescription was not even signed. And finally, in the pre-treatment review and verification, the failure mode cause combination was plan reviewed incorrectly by attending MD, plan review because the plan was reviewed by a covering MD or the MD was rushed. Now, I don't mean to pick on MDs, but many of the causes of the high-risk failure modes that we found were due to MD errors, miscommunication, or the MD was being rushed, or there was inattention, or there was a covering MD. So we strongly recommended that these be included and some sort of Peer review happen if necessary. After the FMEA was complete for each section, but mostly for these initial plan and chart checks for external beam, we validated the results using the following. There were team members who had in-house incident learning systems. We also looked at two very large incident learning systems, Royals and Saffron. Royals is our national database, and Saffron is international. After looking at those, we added 10 failure modes with 6 causes, but they all happened to be low risk failure mode combinations. So we were confident that we covered all of our bases. But we did do that survey that I spoke about. This chart is very interesting, and it's inside TG275. This compares it is a graph of the frequency of the check from the survey on the y-axis and the RPM number for each failure mode that we identified with those checks. The green represents the treatment planning process step, red is the simulation process step, and blue is the patient assessment. If you take notice of the points in the upper right-hand quadrant, these are all high-risk failure modes, but they also were high response rates on the survey. So we were confident that those were the failure modes that were being checked routinely. Of concern, though, is the lower right-hand side, where the failure modes are high risk, but the response rate of the survey was below 60%. This was an indication that we should include these failure modes in our recommended checklist. Also of concern is the left-hand side of the chart. Notice all the points with a failure mode of 0. Lots of green ones there. Why are physicists taking time to check items that have basically no risk? In most clinics, treatment planning systems download the information electronically to the information management system. For example, MU, field size. So there's very little to be gained by doing this check. Only in a manual transfer should these things be obviously checked and much closer. Final recommendations for initial plan and chart review were the following. We recommended that a QMP, or at least a person supervised by a QMP, to check the chart. We recommended that the initial plan and chart review include a replan with limited distractions. When? As early in the process as possible. In fact, we recommended that the initial plan and chart review occur at least before the first treatment. And why? Because the lists that we have recommended, the checklists that we recommended, are high risk, high priority items. So what did we publish? We published checklists, but the checklists are a little bit different. They're based on the high risk and high response from the survey. Everything that was in the upper right-hand corner of that chart, as well as what was in the lower right-hand part of the chart. But we recommended that the checklist be adapted for each institution, that everyone look at their process and adapt that checklist for their process. We also recommended standardization, to add automation to a chart check, enforcing functions. And the last two, I think, are extremely important. We recommended recording anytime you find a deviation, tracking them, categorizing them, and analyzing the deviations so you can learn from your deviations and modify your process. And last but not least, this is a big bug of mine, as with every team member, that physicists must insist on a sterile cockpit when you're reviewing a chart or a plan. So many times we get interrupted, and when we get interrupted, there's less attention to the chart check and the plan check, and therefore mistakes can happen. Recommendations for the weekly chart review are also based on high risk and high response from the survey. They include items that can be missed on an initial plan and chart review, as well as additional information obtained after the initial review. It only contains items that can be detected by the physics checker. All other items should be on somebody else's list. Can't ignore them. They've got to go on somebody else's list. There are caveats on our checklist because there's some items that are identified as first weekly, must be done on the first time you check that chart during the course of treatment after the initial plan chart review. Then everything else would be recurring or end of treatment. So we specifically identified those. I think special attention should be highlighted with hypofractionated cases, because a hypofractionated case may occur within 6 days, at which case you may do the first weekly, but then it won't get a third or a second weekly. So individual departments should review their chart checking procedures for hypofractionated cases, especially those that are delivered in less than 6 days. Fifth and final review question. TG 275 recommends all but the following. Checks should be completed by a QMP. Checks should be performed as early in the process as possible. Checks should include high-risk, high-priority items. And checks should be recorded, tracked, and analyzed.
All right, great. This question is up in the polls section, so you can go ahead and weigh in. Give everyone just a moment to answer this before we move on to the correct answer. And I see that we have some great questions in the chat, so thank you so much for everyone who's asked a question. We're going to get to that very shortly at the end of the presentation here. All right, looks like a lot of folks, I think, are getting the correct answer on this one, Dr. Greener, so I'm going to go ahead and end the poll.
Okay, and the correct answer is number 1. Checks should be completed by a QMP, because we recommended not that they always be completed by a QMP, but a QMP or someone supervised by a QMP. So that's the exception. All right, in addition to external beam radiation therapy failure modes, TG275 put a small group together to address GYN brachytherapy procedures. We couldn't tackle all brachytherapy procedures, so we decided to narrow down only with GYN. And here are some of the failure modes that were listed. And recommendations for GYN brachytherapy include checklists that were high risk, and they're ranked from high risk to low risk. And they not only include technical, but also clinical information in clinical failure modes and causes, just like the external beam. Documentation should be complete and accurate, because I think that was identified as one item that, because it's a high stress limited time frame, you end up, the record tends to be filled out or completed later on. So good, complete, accurate documentation is very important. And high stress limited time frame, HDR is truly in this category. So we recommended an independent check. And if you can't have it, if you're the same person that planned and checked, then we recommended delayed verification, self-verification after some time delay. Hopefully that's in your practice, where if you're doing the plan, then you take lunch, you come back immediately after lunch, or short break, and you can immediately back, and you do another verification, a self-verification. It's been proven that this time delay in between the plan and the verification is very helpful. We had another small group that identified proton failure modes. And I'm not that familiar with proton failure modes, and some I found extremely interesting, like the patient setup mismatch, where the hair is not in the same place, or it's wet versus dry. I consider that more like an immobilization device. So But these were pretty interesting for me anyway. The recommendations, again, were checklists. High risk and high response from proton physicists only. We did a special, the survey that we sent out had a special section just for protons. And finally, the key recommendations as we walk away from TG 275 and try to implement it into our own clinics, I broke up the key recommendations into 3 categories. The reviews themselves should be based on risk analysis methods, and we used FMEA, and we absolutely encourage clinics to use that. Form a team, look at your process, and you can use the same failure modes that we came up with and see how you rank them in your clinic. But identify the high risk and or high potential severity. Failure modes that are outside of the purview of a medical physicist should definitely be considered by other department groups. As we've already discussed, that these plan reviews should be performed by a QMP or supervised by a QMP, closely supervised by a QMP, by the way. The definition is included in the report. Perform the review as early in the process as possible and use tools to standardize and enhance the review. Then we also had recommendations for the clinic. Develop standardized policies and procedures. Perform an ongoing review of your policies and procedures. Use the incident learning systems. If you don't have one internal, you can use Royals. Provide staff with the tools and environment for success, meaning that sterile cockpit and maybe automation tools if necessary. And avoid manual transcription at all costs. I know sometimes there are plans, if they're emergent plans or some type of plan that cannot be planned, you can't get an image, but you're at least going to put it into the treatment planning system, the treatment delivery system. Be very, very cautious with manual transcription. And we had some recommendations for the vendors. For them to aim to employ design features and forcing functions in their software, to develop automated tools, and but mostly to consider this human computer interface for easy review so we can minimize our errors. And lastly, to develop workflow tools to enhance communication between different sections, the MD, the RTT, the nurses, the physicists. So I hope you take time to read the entire report. I know it's a lot, and incorporate the recommendations into your practice. We have made available these checklists and these failure modes in not only publication form, but also online. The more, the larger list are online. So please take the time to take a look at these, and hopefully you can implement them in your practice. So thank you very much, and I look forward to questions.
Okay, great. Thank you so much, Dr. Greener, for presenting this topic today. We're going to scroll down to the bottom of the chat, and our first question is from Dustin. He asks, the medical physics practice guideline published by the AAPM seems to be prescriptive based. Do you expect this to remain, or is there a movement to shift the MPPG to more risk-based paradigm?
Well, they're supposed to work in concert with the TG reports, so that you have the MPPGs and then you have the task groups. Well, the task groups come first, and then the MPPGs are supposed to take some information out of the TG reports and work in concert. We have 2 members of our TG 270, well, we have members of our TG 275 group on several of the MPPGs, and we definitely very strongly give our opinion. So no, I think they're going to eventually move more to a risk-based paradigm.
Thank you for answering that question. Our next question is, how is the risk-based versus prescriptive going to play out with ACR or state regulators?
Well, that's a very good question, because currently the regulators and ACR will take a look at those TG40 and TG142 reports and so many others, and will say, oh, are you following all these recommendations? Well, if you can prove to them that you have performed an FMEA and determined that in your clinic there are some low risk failure modes causes that don't have to be checked, then that's a good discussion during your site visit and with regulators as well.
Thank you for that. Our next question here is, at your institution, at what point are your physicians expected to approve initial films?
Our physicians approve the initial films before the patient receives their first treatment. They're at the console, the treatment console. They're called to the treatment console at the time of the image before the patient gets treated for the first time.
Okay, thank you. Our next question here is it okay to have weekly check chart done by dosimetry or temporary basis, vacation, etc., regularly?
Not regularly. What I would recommend is that number one, you have to have documentation that the dosimetrist had proper training in order to do that chart check, just to cover yourself. And then the second recommendation would be to have some supervision of the dosimetrist. And on a I have done that in the past. I've trained a dosimetrist. When I was a solo physicist, I trained a dosimetrist how to do weeklies. And my approach was that they would do weeklies. I would do all the initials, the very first weekly. So the physicist would always do the first weekly, and then the dosimetrist would pick up doing the second weekly, and then I would do the third. So we would alternate, and that worked very well.
Thank you for answering that question. This is a similar question. Could physics residents do weekly chart checks, or it has to be a quote fully certified physician?
No, again, this is very like the first, that last question that we just had. Yes, of course, physics residents should be able to do weekly chart checks as long as they're properly trained and supervised by a QMP.
All right, thank you for answering that. Our next question, how do you evaluate severity in an objective, quantitative way?
That's very hard to do. If we go, I don't know if I could go back to our list here. Can everyone still see the slides? I'm trying to go back to our table from TG275, which actually came from TG100. I'm going to have a hard time getting back. I'll just keep going. But severity is not necessarily, I don't think it can be a quantitative. It has to be more objective. It depends on the reaction that the patient is having, or if there's here's the severity. So no effect all the way to catastrophic. But how would you identify a minor dosimetric effect? It could be a minor dosimetric effect that really isn't going to have much, it's minor, so it's going to have not much of an effect on the patient. But then you could have, if it's a dosimetric error that has some toxicity or even an underdose of a tumor. So I don't think you can quantitate it. It's more qualitative.
Thank you for answering that question. Our next question here is, at your institution, do you film electron fields?
No, we do not.
All right, thank you. Our next one here is your treatment planning system configured for electron beam treatment?
Yes.
Okay.
It is. Great. Although, yes, it is. But we're moving more towards a Monte Carlo system. So currently we're doing pencil beam, and you do have to be very, very careful in interpreting those isodose curves.
Thank you for answering that question. Our next one here is, why does high response from the survey weigh in on the checklist?
Well, we used it for that comparison to see in a validation of the failure modes. Are we missing any failure modes? that were then on the survey, the survey response, give us 100 with a very low risk. Well, should we include that? Should we not include it? So low risk, we decided that the survey was important to give us a baseline on current practice.
Thank you for answering that one. Our next question here is, if the first weekly chart check is made before the third fraction, then you cannot get paid for it. Is there a solution for billing for having the weekly chart check earlier?
Not that I know of. You have to bill. You have to bill once in a course of treatment, once every 5 fractions. And as far as I understand it, and I'm working for the VA right now, so I'm out of the real strict billing guidelines. But as far as I understand it, the chart check itself does not have to be linked to the charge on that particular day. Because remember, the charge does not validate only the fact that the chart was checked, but it also includes, if you look at the specific guidelines, ASTRO puts out billing guidelines every year. If you go to the specific billing guidelines, includes not only the physical chart check itself, but all the QA that you do, the monthly, the daily, the weekly, the annual. It's all the physics workload that's put into keeping the clinic going and treatments being delivered.
Okay, thank you. This is a similar question. Why does the first weekly chart check have to be done within the first 3 fractions? We usually do it within the first 5 fractions.
That's correct. The reason we recommended it was because the first weekly has more checks involved. If you look at the checklist from 275, we added more checks for the initial, for the very first weekly. They included items that may have been missed on an initial plan review, and better to check that as early in the process as possible. This is, I follow this practice where our first weekly, if it's over 10 fractions, is always the 3rd fraction. If it's 10 or less, we do it after the 1st fraction.
Thank you for answering that question. Our next one here, did you account for differences in EMR or equipment which could lead to differences in occurrence rates?
Well, we had a variety, our team represented a variety of clinics, and there was a variety of equipment and EMRs throughout all those clinics. There was Varian with Mosaic, there was Elekta with Aria, there was all Varian, there was all Elekta sites. So I think we had a pretty good cross-section during our FMEA cause scoring.
All right, thank you for answering that one. Our next one here, would the TG publish some basic templates for the checklist?
Yes, there are. Well, there's some recommendation. There are. If you go into, if you go into the publication itself, there are some guidelines there. There are some specific items that should be checked. And then there's a full listing of our checklists electronically.
All right, thank you. Our next question is, the process for performing FMEA and developing checklists is very consuming and requires participation from multiple members of the radiation team. In a very busy clinic, just trying to schedule time together with no patients or interruptions becomes impossible. Do you have any recommendations for overcoming this obstacle?
Yes, I do. We actually performed an FMEA on physician peer review. And we do peer review on a weekly basis where the physicians review contours and they review plans. So essentially our treatment plans get reviewed twice by a physician, by a second physician, not the original one. And we collected all of the comments from those peer reviews, and we had a team together that did an FMEA. The team doesn't have to meet together. In fact, our TG275 team met together many times, but we did all of our scoring on our own, based on our own clinic. So you don't have to have the team together. You might have to organize the team together, but then the scoring can be done individually without meeting as a team. And then the team leader can collate the information and prioritize.
Thank you for answering that. Our next question here is there a role for reviewing images during weekly chart checks? We have found occasional occasional issues or trends not noticed by MDs?
Yes. Reviewing images, yes, there is a role in weekly chart checks. And we do that in our clinic. We have available all of our weekly images available to us, and we include that in our chart checks. So yes, definitely.
Great. We just have a couple questions here left. What are the billing restrictions for the weekly chart checks?
Well, as I said before, that the weekly chart check should not be based on every fifth fraction. And if you look at the ASTRO guidelines, it'll give you some more clarification. It's based on all of the QA that you do. So you can do a chart check earlier in the process on the third fraction, but bill it on the fifth. There should be no, check the ASTRO billing guidelines, because like I said, I'm out of the billing specifically. I'm not an expert in billing, so you're best to refer to the ASTRO guidelines for that.
Okay, great. Thank you for reiterating. How do you practically keep track of new charts that need to be checked within 3 fractions as opposed to regular charts every 5?
Well, we use Mosaic in our clinic, and we also use QCLs, which is a quality checklist. So we have some quality checklists that are automatically sent and some that have to be manually sent. So if a patient has completed their first fraction, then physics gets an initial check QCL to say that the initial check has to be done. It's different. And we don't have QCLs for weeklies. Weekly, it's up to the physicist to just look at the list of patients that have to be checked.
Thank you for answering that. Our last question here. Do you have a recommendation for a minimum number of people required to score failure modes to calculate RPN?
I don't think I can recommend a minimum number, but I can definitely say that in this case, it should represent either a variety of clinics or a variety of individuals within the clinic that are involved in chart checks. So maybe if you have a large clinic and there's 10 physicists and you have 5 dosimetrists, then maybe 2 dosimetrists and 3 physicists, something in that number. So you can have certainly not 1 or 2 people doing an FMEA, you need more.
All right, great. Thank you so much for answering all those questions. And thank you, Dr. Gruner, for presenting this webinar. And thank you all for joining us for this free event hosted by WePast. This webinar is going to be available on our YouTube channel for the next 7 days. So if you need to review this presentation, be sure to check it there. And this and many other recorded webinars are always available to WePast subscribers 24 hours a day, 7 days a week. So we want to encourage you all to register through WePast.com and become subscribers. And for up-to-date information about upcoming webinars, be sure to follow WePast on Facebook, Twitter, and LinkedIn. And if you have a moment, please help us improve our future webinars by taking this short survey. Thanks again.